want you to have. One is the summary statement for actual therapy, and then the other is just it's a real anesthetic record for a real case that happened in Spartanburg in January of 2019 where the kid died. So we're going to use this a little bit and this a lot, but just getting started. Because malignant hyperthermia is such an uncommon event, it's said to happen like 1 in 100,000 in adults, 1 in 50,000 in children. It's very uncommon that you would see it even in your career. I used to work at a children's hospital, and I was actually involved with 3 cases in 18 years, but that's unusual. So because of that, we have all of these placards posted in all of the operating rooms, and we have cognitive aids that are in the operating rooms that are designed to help us remember what the right things to do are, because it's not something that we do very often. In fact, you might never do it, hopefully. But what I wanted to do is at least go over briefly the concept of how to do this correctly, realizing that if it happens, it's unlikely that each one of these things are going to come to your mind immediately. And that's the reason why we have cognitive aids, and that's the reason why we have placards on the wall, is just as reminders. So, as I will talk about later with the case report, making the diagnosis is important for the outcome. And what we know is that for every 30 minutes that you wait, the risk of a significant morbidity and mortality goes up by about 50%. And so, like, if you wait a full hour, the likelihood of you having a death goes up dramatically, 200%. So quick diagnosis is important, but one of the problems with malignant hyperthermia is that it's kind of well, it has a lot of sneaky presentations, and what makes it even worse is that it doesn't always happen every time somebody has an anesthetic, even if they're very susceptible to this disease. So, like, I actually reviewed 38 cases in Kansas City that happened over 40 years there, and we had cases that happened on the 5th anesthetic. We had cases that happened on the 1st anesthetic. We had cases that happened in the first 10 minutes of a case. We had cases where they would happen 4 hours into the case. And so it doesn't happen every time the way you expect it. And a high temperature is actually a very late sign. And so if you're waiting for the temperature to go up to make the diagnosis, you're going to miss a lot of them. You're not going to miss them, you're going to wait too long, and they're going to have a very poor outcome. And so, as is exemplified in this case, the patient's temperature never goes up, at least according to the anesthetic record. But what you can notice on here is that the end-tidal CO2 within 15 minutes is in the 50s. And the kid, first of all, let me just tell you about the patient. He's a 19-year-old. He's already had shoulder surgery, and he's having an ACL reconstruction now. And he's 230 pounds, probably a fit football player. And on his past medical history, he reports that he's had a recent cold. So even if he had a low-grade temperature, it wouldn't necessarily trigger you to think that he's having an episode, but maybe it would. He's got a liquid crystal skin temperature strip on, and the problem with those is that they're notorious for being good as far as showing temperature trends, but being very poor for actually showing you what's going on as far as a core temperature. So if you put one of those on in a cold room, it might read, 34 degrees because the room's cold. And the patient might actually be 37 degrees, but it doesn't read a good temperature. But if you see it go from 34 to 35 to 36 to 37 in a short period of time, it's good at least showing a trend if it's going upward like that. And so the liquid crystal is better than nothing, but it's not a great way to monitor a core temperature. So if you look at this, his temperature is normal throughout the whole case, even after he's had a cardiac arrest, which happens at about 10 o'clock. If you look at the end-tidal CO2, it's climbing. And that's one of the reliable early signs. Problem with that is that he's also breathing spontaneously, and he's got sevoflurane, and if you take 100 people and have them breathe sevoflurane, their end-tidal CO2 isn't going to be 40, it's going to be 50 or something like that. It won't be 69, but it's not going to be 40 because the sevoflurane blunts your brain's ability to respond to carbon dioxide. The other thing that you'll notice here is that they're just pounding this kid with Dilaudid. And so, he gets 1, 2, 3, 4, 5, 6 doses of Dilaudid. And the only reason that I can think of that they would do that is that he's acting like he's light and that he's hyperventilating. And so, in spite of the fact that he's hyperventilating and has a high CO2, which are both signs of malignant hyperthermia, they're treating it as though it's pain-related or light anesthesia-related and literally pounding him with Dilaudid. And Dilaudid also makes you not want to breathe and respond well to carbon dioxide. So even though this diagnosis is late, I think that there are a lot of early signs that are happening here, and this is one of the problems with most of the cases. You have to think about it before you can actually diagnose it. And I don't know at what point in time I would have thought of this if I were doing the case, but probably 15 minutes or something, not 60 minutes or it's at least 60 minutes before they even act like they're thinking about it. But having said that then, they call me into the room, I evaluate the situation, I say, yes, I think we have an potential MH episode going on here. Get the card. Where is this card located?
Orphan desk.
Right, so it's right off of Dan's desk in the main area there. Most of the time when you see an event, it'll happen in the operating room. It can happen out here, it can happen at home, but 99.9% of the time I'm going to say you'll see it in the OR first. 25% of cases can have a relapse later, so they need to go to the hospital, they don't need to go home. But of the cases that are diagnosed, almost all of them happen in the OR. Theoretically, it can happen out here in PACU afterwards, but I haven't seen that. So we're going to get the card. And then we're going to utilize some kind of cognitive aid, because I think that it's been shown that when the landing gear doesn't go down on an airplane, they get out the book. When you have a critical situation, particularly a rare situation in the operating room, get out the book, because you'll do a much better job if you have the book. And you just read through it. It says, get the MH card. Cease all volatile anesthetics. So you turn the gases off. because that's usually the thing that's making it happen. It could be succinylcholine used for intubation, but if it's not succinylcholine, then it's one of the volatile agents. So acevo, desflurane, halothane, isophorane, ethane, methoxyflurane, ether, all of those things can make MH happen. So we turn that off, we turn the oxygen up as high as it will go and start hyperventilating the patient. You let the surgeon know that you've got a spaghetti hitting the fan situation, so that he knows that he needs to end the surgery as soon as he can, and it may not be soon that he